we're super pleased to have everyone here who's doing important work, taking the vanguard in how to create good healthcare for people on the street forward from the stuff that came out of the COVID business. So, without further ado, thank you very much. Let's go.
That was the quickest intro I think ever. Okay, hi everyone.
Hello.
My name is Clancy. I'm a part of LA Poverty Department and have been helping create conversation around the COVID hotels and the IQ sites. I'm always IQ or QI because we've got a big paradigm separation there. IQ or QI? Yes. So this is a special panel for us because this exhibition, which has been up since March, has really highlighted just what happened during COVID and how different forces were mobilized to take care of the unhoused population and how some really amazing innovations emerged from the adversity of that time. Which we'll get into specifically, but this exhibition has been around honoring that chapter and honoring what happened and then creating more conversation about how to kind of break apart what was successful at the QI sites and kind of understand why they were successful and how they might be implemented in the future in other ways for how to take care of this unhoused population as we see. That's where here we are in the Skidder History Museum and Archive. But so it's a special moment because it's the last panel of the year. This has been going on since March, and we've learned a lot from different folks, and there's been a lot of momentum from like the audience and people who listen to the panels about, okay, well, what do we do next? Like, how do we make sure that this is? How do we make sure that we can? Why aren't they continuing? How can we continue all the innovation? And so we're kind of this panel is really about, well, where are we now? What is the landscape of essentially services for this population in Los Angeles, and what are these different programs that we feel and have heard are doing a really great job at taking care of folks, specifically because they're implementing elements that were useful in the QI sites. So some of those things being, utilization of harm reduction, collaboration between different normally siloed institutions like the Department of Health versus the Department of Mental Health, and low barrier to entry, round-the-clock services. There are lots of different elements and building blocks that I can name more and we can get into. But anyway, so we're so curious to hear what's happening now, and we have this amazing panel of folks here who are kind of like representatives of a couple of these incredible programs that show you, it's like a snapshot of what is happening right now in LA County. So just to introduce you, and please correct me if any of the verbiage is inadequate, but so we have Dr. Shayan Rab, who is the Associate Medical Director at the LA County Department of Mental Health, who was dubbed LA's First Street Psychologist, and he will be here discussing the home team, the Homeless Outreach and Mobile Engagement Team. Did I miss anything?
You did not. That was great.
Okay, awesome. And we have Gabriela Ramirez, who is the manager of the Interim Housing Outreach Program, aka IHOP. Is that right?
Not pancake.
People might be familiar with a different IHOP, so we're going to learn all about the real IHOP. And so same thing happens with LA Poverty Department. People think we're LAPD, but we're not LAPD. And then we have Victoria Onwualu,
Yes.
and Director of Housing and Health Programs with Wesley Health Centers and the JWCH Institute, who will tell us all about the Safe Landing Site programs that she oversees at the Cecil Hotel. So, okay, so what we're going to do to get started is I'd just love to hear from each of you, can you share what your program is, kind of introduce yourself in a deeper way, share the program that you're involved in now, and specifically if you could position it in the larger kind of spectrum of the housing continuum. So, because there's a lot of different, you guys are all kind of covering a different reality for folks, so you could talk about what the program is, who you serve, and where it fits in the housing continuum, and then there's a lot more to share. So perhaps we could start with, let's start with Dr. Rab.
Okay, yeah. Hey everyone, it is an honor to be here. To describe, I'm the Associate Medical Director for Street Psychiatry, essentially, for the Department of Mental Health. And the program that kind of created Street Psychiatry for the department is the home team. And the way for me to best describe what we do is to give you an example. If you look at our mental health system, what is the mental health system? It's basically a collection of different levels of care. Like you have your outpatient levels of care, which is your clinics. You have your residential levels of care, which might be your boarding care facilities, your housing resources. Then you have an inpatient level of care, which would be your inpatient psychiatric facilities. And you have your emergency rooms, which is another place where you can get emergent psychiatric services. Now, if you're someone who is housed, you can typically navigate this full spectrum pretty well, or if you have supportive people in your life, you can. But if you are unhoused, and specifically if you have a serious mental illness, can you walk into a clinic and get consistent care? No, you can't. It's too far away. It's hard to wake up on concrete and make it to a 10 a.m. appointment. Can you just walk into a boarding care to get placed? No, you can't. You need to have medical clearance, you need to have labs, someone needs to vouch for you. You can't use drugs, you have to be a model citizen to live in these facilities. Sometimes it fails as well. Ultimately, folks don't get the services that they need and they remain on the streets, declining more and more and more, ultimately to the point where crisis response team starts getting called, the police start getting called, and then you start being launched off to emergency rooms and inpatient units, which aren't designed to help address homelessness or treat long-term, provide for long-term mental health needs. So they just cycle right back. So people with serious mental illness and chronic street homelessness were just trapped through barriers and revolving doors. And the outreach world, God bless them, was trying their best to help these folks, but without treatment they couldn't get anywhere. Most outreach teams did not offer treatment. There were some field-based teams that the Department of Mental Health had, but you had to meet very specific criteria, a certain number of hospitalizations, you needed to fail a certain number of things, and then you could be pulled into these teams, and all of them were full. There was a need to create a special team that sat between all worlds. They had their foot in the outreach world, they had their foot in the inpatient world, in the ER world, and above all, they had treatment providers who could integrate the rest of the system. That's what the home team represents. In many ways, it is a multidisciplinary team that brings all aspects of the mental health system to the footsteps of whoever needs help. And that's what the home team is. It's a multidisciplinary field-based team with social workers, community health workers, with substance use counselors, nurses, and psychiatrists. Each team has all of those components, and there's now 18 of these teams, which comprises 233 staff members. It started in 2019 when we had all the pieces except psychiatry. I was the first psychiatrist. I wasn't the first street psychiatrist ever. I was the first street psychiatrist for the department. And when that team completed, it showed that when all of these specialties work together, you can make some serious magic happen, including providing treatment to people and getting them housed if their symptoms are interfering with their housing. That started out with a small the first team to actually do that was right here in Skid Row in 2019, and now over the past 5 years, it was just a team of 20 people, but now it's gone to 233 staff members, and we're serving about 2,000 people every single year. So that's what the home team is. It's a multidisciplinary field-based team. In many ways, we're like an open-air hospital because we integrate with all different services that the entire county has, and our goal is to get people housed and reintegrated into their communities.
Thank you so much. Gabriela, can you share a little bit about the IHOP?
Absolutely. So go ahead and follow Dr. Rab's footsteps in regards to the introduction of the home team. I was actually part of the home team as well before it became the home team. It was just a homeless outreach program, but then, like Dr. Rab said, there was a continued need, right? Not just to bring food to our clients. There was more needs that our clients needed because they were just so ill. Grave disability was going on in the streets. So the home team that's what they do on the street, serving individuals that are out in the streets. The IHOP team was developed from the home team because not only during the pandemic, but just in general, we saw a huge need for our clients once they were placed indoors, right? Because that's not the end of their problems, right? They still, our clients they struggle quite a bit, and I think sometimes even more because now they're indoors. How do they do life, right? So through the pandemic, we saw a huge need that, at the IQ sites, at interim placements, that, clients continue to struggle. So how do we support them? So through the pandemic, we saw a lot of lessons to be learned, and that's when we started to see the need of more additional services to be provided. So the IHOP team was created to provide those wraparound services at the interim sites, right? So this is another team that is multidisciplinary. We have clinicians, we have medical caseworkers, community health workers, LVNs. So there's a prescriber aspect to the team as well. We have psychiatrists, we have nurse practitioners. So this whole team comes not only DMH, but we also partnered with Department of Health Services and Department of Public Health. So very unique approach because we have three agencies coming together and working together with one common goal, right? So the common goal is to not only support the clients, but to prevent them to become street homeless again. So this is the first time this is being piloted, where three departments are working together to a common goal. And like you said earlier, we're used to working together, but kind of like in silos, right? Like, okay, you're over here, we're over here, and we may come to an agreement, but with IHOP, we have treatment plans that are specifically working together to help our clients. And the ultimate goal is for our clients to have supportive services. That's with either DMH, also with health services, public health, and the ultimate goal is for our clients to get permanent housing with supportive services. So it's we're already providing services here in Service Area 4, Service Area 6, and we're going into Service Area 2. So as we speak, we're rolling out the services, great outcomes already. And we have our first nurse practitioner that started about a month ago, and we're already seeing clients out in our placements, providing prescription support and medical, along with DHS and DPH. DPH, Public Health, they're providing the substance use education and support. So that is harm reduction. So they provide, harm reduction items, Narcan education. So, we're up and running, and a lot of great outcomes are already, being done out in the. So our clients are in the interim placements. They're already there. They're housed there. But like I said, the ultimate goal is for them to get permanently placed.
Can you just define interim in a very clear way so that makes sense? Interim, maybe some folks might need some more support understanding.
Yeah, so interim placement would be like a tiny homes. It can be a shelter, or it can be a hotel, as some of the hotels were turned into housing during COVID. So that would be interim placement. So it's not permanent. It can be 60 days, 6 months, up to a year. So just depending on the site. So.
Yes, thank you. And you mentioned that, so IHOP converged out of the home team.
Correct.
And
It was
so
modeled.
Okay. And what year, so home team 2019 it started?
Well, Home Team was there before 2019, but the modern version of
Yeah.
Home Team began in 2019 when finally all specialties were at the table.
Got it.
And Home Team's job was to take people who were completely disconnected from community, completely untreated, place them into housing, and then make sure that they develop roots in their new housing and build a sense of community. But imagine carrying that client from one end to the other end. That takes a lot of workforce to time commitments. So that's why then the department was like, well, you know what, if there's people that are remaining in temporary housing options before they go to permanent, perhaps there can be a new level of care that we create at these interim sites that can carry the baton forward, so that way one team is not just carrying the entire load, and IHOP was kind of born from that.
Awesome. Okay. And what year would that be, just for the record?
So for IHOP?
Yeah.
So IHOP started just with the Department of Health Services November of last year.
Okay.
So that's just DHS. And DMH, we just started hiring July of this year.
Okay.
So we currently have hired approximately 70 staff.
Wow. That's
Yeah, so
okay.
we have, and then from those 70, we have about 35 people out in the streets every day.
Okay. And your role specifically within that, Gabriela, can you just?
Yes, I'm the program manager.
Okay.
Yes.
Awesome. Awesome. Thank you so much. Okay, Victoria, can you tell us a little bit about your work and the Safe Landing Sites?
Okay. Hi, everyone. I'm glad to be here with you all. Like I said, my name is Victoria. I'm the director of Homeless Housing Services at JWCH. For those of you that don't know, JWCH, we have various housing continuum. We have the RICU, which care mainly for those that have physical issues, substance abuse, and mental health. We started the Safe Landing, as you guys know, in February. But if I can go back to give you the statistics to now. In February, we opened the Safe Landing, and we made it open. It's a 24-hour facility where anybody homeless in this area will come in and receive services. Usually people will say that unhoused are difficult to remove from the street. I disagree and don't disagree with that in the sense that maybe you have not approached them the right way. If you approach them the right way, you will be able to work with them to be able to get them off the street. With the Safe Landing that we have on Main, Cecil Hotel, we started February 15th or February 5th. To date, we have served 1,800 homeless people. I would say we have removed 1,800 homeless people from the street. The main reason why I would say what we're doing is working. We don't force anyone. We're open. You walk in. We don't even talk to you about housing. What we are there for is to give you a bed, shower, and food. If you're able to take that, we can then go into what is going on in your life. We do the assessment to find out what do you need, what type of housing are you looking for. If it's someone that have physical issues, which you all know, our unhoused people come up with a whole lot of physical issues. Unfortunately, it is the truth, but it's not that we overlooked it. Being unhoused makes it so difficult for you to even remember you have an appointment. Being unhoused makes it difficult for you. I go to the hospital and the doctor said, oh, you need specialty care. Do you think I will come back to get that specialty care? No. So I'm unhoused, you're telling me I have breast cancer, I should come back to go to the lab. I will not remember that. I'm going to walk away and not come back. So with opening of Cecil Safe Landing, we welcome everybody to Cecil Safe Landing. And when they come in, we have various tools to look to see where the person is. We look into ORCID to see if you were recently admitted. We look into LANE to see if you're connected with any services. And I will tell you what I have seen is troubling for our unhoused people. I remember having the first time we opened Cecil, We opened our door. The first gentleman that walked into Cecil was happy to come in under the roof. Took a shower, we changed because we encourage you to take a shower if you want to, but there is nobody that wouldn't want to take a shower if given the right opportunity. It's very calming. So he went and took a shower, we changed him, he came back, sat on the door. Unfortunately, by the time he gets from here to here, he will pee on his pants. He did it 2 or 3 times. I went and called the DHS person. I said, this was how my dad's prostrate started. He may be dealing with prostrate. So, having a recoup facility, we thought sending him to a recoup would be better. And having access to Orchid, we were able to find out in 2019, he went to a clinic where they told him his PSA level was high. But 2019 to this year or to February, he did not go back for treatment. We presented that to him. He was willing to take it, and we were able to send him to a recoup facility. Good enough, he's now getting treatment for the prostrate, which I think it is needed. So overlooking the medical need of the unhoused calls for attention. Yes, COVID hit. It's a lesson learned. We got something out of it. The unhoused got more attention. That the attention the unhoused got is what is leading to development of all these housing. So going back to Cecil Safe Landing, when a participant comes in, we assess the need. If the person meets the criteria for interim housing, like she said, we will move the participant to the interim housing. If the participant meets the criteria for a recoup, medical issues, we've had people discharged with heart condition, we will then move the person to a recoup. If it's just an ordinary substance abuse, we will go into the substance abuse placement. We've had people walking, running away from domestic violence, which we have triaged with the domestic violence housing services and be able to move them. So that's why we take a look at what we have. The continuum of care will help provide services. I remember if we move some of the clients, we have is our SJO St. Julian psychiatric bed. I walk in there, one lady was like, didn't I see you at Cecil? I'm like, yes you did. And it helps to be able to look at each client and be able to say, this person will work best here than here. In July 15, we started the interim housing that is on DTLA, the downtown hotel. When we started it, we felt like, oh, okay, it will never be full. Today, we're already full. The good news is that in each of our sites, we have case managers and social workers and LVN that will continue to follow the client. The case managers and the social workers will look into applying for housing. They look into HMIS system to see if there are any housing applications submitted for the person. If there is no housing application, we will go ahead and submit it. If it's been submitted, we will then start calling to see is there anything in the pipeline. Having opened DTLA in July, I would say that we have permanently housed about 8 clients. Some people may say that's it, but from July to now, having 8 people permanently housed, it's a big step in the right direction. So there is no services in this area that will be enough for the unhoused. I think we need more services. I think we need more help to be able to house the unhoused and to be able to help deal with the issues that they are having. And that was why we made the Cecil Safe Landing 24/7. We've seen people walking by 1 a.m. We've seen people walking by 10. 11. I came from there. Somebody just dropped me when I was like, where do I park? I'm like, forget it, let me just park over there and then walk down here. So it takes a village, like they said. So it's going to take the act of everyone here in LA to be able to help them unhoused. I know the governor came down and was talking about the unhoused. Yes, we're happy we're going to have Olympics.
Yeah.
It may help us to be able to house the unhoused more with that Olympic coming up. So it's a blessing for us and we're happy to continue to help. Thank you, everyone.
Thank you. Yeah, so thank you all for the intros. It's really clear just from what you've shared already how these building blocks that made the QI site successful are being implemented. You talked about like 24/7 facility, utilizing harm reduction in some way, the importance of relationships. It sounds like not just in meeting the person where they are and seeing the whole picture, including the health, mental health, but also in the relationships you build across with other organizations, because in order to house that person, right, you have to know where to go, who to call, and all of that.
Yeah.
So, people who've been to previous panels, it's very clear how these things are being used right now. So that's very hopeful and quite exciting. Can you, whoever would like to, or perhaps Dr. Rob can start, talking about previous panels we talked a lot about just the intersection of housing and healthcare, right? And that's something that we just kind of brought up. So when working specifically with the unhoused, I think our two previous panels were actually titled Housing is Healthcare. There was a lot of momentum around that concept. So I'd just love to hear from all of you, how these programs are collaborative, how folks' health needs and mental health needs and housing needs are all addressed in the different ways that your programs work.
So I can start with that. Homelessness is not something that started yesterday. It's been around since the dawn of time in many ways, but people have been living in these conditions for an exceedingly long time. If you do that, you're going to develop, you might have actually entered into homelessness because of a mental health condition. That's not going to get better if you remain on the street. It's only going to get worse without treatment. And if you stay in the treacherous terrain of the street, you're also going to develop physical health conditions as well. It's not surprising that people who are experiencing homelessness die at such early ages, as early as 40 to 50 years of age. So when you're working with someone who is seriously mentally ill, has a serious health condition, you might be able to offer them housing, but they might not even be in a position to accept housing because either they're living in a delusional state or they're accustomed to their way of life and they aren't ready for that transformation. So you actually have to activate every single resource available. What I have found is oftentimes, at least from the people that I work with, I rarely ever see pure mental health. There's always some physical health condition that's occurring simultaneously, which is why our evaluations on the street always, we have psychiatry, we have doctors, so we're doing that assessment right there. Curbside, figuring out exactly what's going on. Now we even have mobile labs, so we're drawing blood in the street to see what's going on with someone's body on the inside. But the moment our assessment reveals that there is a physical health condition, it could be hepatitis C, it could be, is that a question?
No, it's later.
Okay. It could be hepatitis C, it could be HIV, it could be diabetes, it could be seizure disorder, something gets uncovered. The moment that happens, again, the collaboration coming out of COVID, we call our street medicine partners. They show up right to, they plan a day, they come out, they assess the person with us, and they start their own treatment. So we start recruiting resources. Now, having housing options on paper isn't the same as getting access or getting someone into that facility. So what we did on the home team at least is build a ecosystem. And how we did that is by actually going to different housing facilities and pitching our program and saying, will you partner up with us? Will you trust us when we say this person is good to come in? And we did that across all levels of care. We did it in interim housing sites, we did it at shelters, we did it at boarding care facilities, we did it across all of the options that the department has. We even did it for inpatient hospitals and ERs. We went and we gave presentations on how we want to integrate with them. And that's what we bring to someone right at the table when we're working with them. We bring every single resource that's available and activate it right away. So We only operate because we can quickly call a provider for whatever need is this person needs. We have someone that we can call. And recruiting them to the table is what allowed us to actually be successful.
Thoughts on that?
Yeah, well, for us with IHOP, like I mentioned earlier, as Dr. Rab mentioned, you know, a lot of our clients have medical needs, right? Medical needs that have been, they haven't been diagnosed, first of all. And, you know, the reality is that they're not gonna get the medical care that they need because that's not gonna be a priority for them, right? For them, it's gonna be surviving, you know, out and especially, you know, if they're out in the street and now in place, there's that level of getting used to acclimating to that. So with IHOP, we have DHS that does evaluations regarding ADLs, so that's activities of daily living. So if they're having issues, you know, with mobility, they're, you know, like you mentioned, you know, maybe they're going on themselves. You know, there's some evaluations that can take place by the nurses. So if they need some equipment, you know, that can be provided for them. If there's a need for them to go into a higher level of care, like a SNF, skilled nursing, thank you. SNF,
Skilled nursing.
Thank you.
Yes.
Or recuperative care, you know, those can be, you know, options that we can tap into. You know, afterwards, if there is a need for a boarding care facility because they have, you know, the needs that, you know, they may need assistance with their medication, with, you know, some medical procedures, that may be something that can be an option for them. So definitely the medical side is something that we take very seriously, and that is one of the initial evaluations that do take place regarding medical. And then we go into, obviously, you know, mental health. If they need a medication refill, you know, we can tap in the nurse practitioner, the prescriber, and they can get that within a day to get their medication started up again. Yes.
So, yes. Yeah. So for us, I would say that our RICU are richly staffed with nurse practitioners and doctors. When I came on board, I felt like I came from DMH. I was in DMH for almost 10 years, 20 years. So I felt like we need to treat the psych components. If we don't, we're treating it, but having someone with going through some psychiatric issues, transporting the person, we risk staff life and client's life. We then brought having MP psych on site once every week to look into those with psychiatric issues. And for me, I encourage people to go on injectable meds if you can, more especially where you tend to forget taking your medication. Good enough, some pharmaceutical companies are coming up with new medication injections that is 1 every 3 months. That's what I normally talk to them, for them to buy into that. It's better for me as a psych patient to get once every 3 months medication shots. I wouldn't do any other thing, or to get a half yearly 6 months, and I wouldn't do any other thing till the next 6 months. But on the other hand, I let staff know if the client gets met, don't think everything is over. Because if they're taking the 3 months, towards the end of that 3 months, you will start seeing some issues. It's for us to address it quickly. If we're not addressing it quickly, it will pass that 3 months, that issues will come back. So looking at it, we're treating a human being, not just one aspect, not the physical. Substance abuse, we've brought groups into our RICU to help those that are ready to talk about their substance use. I've also charged nurses to do groups. It's not about me going to the doctor, getting my meds. I need to know the medication I'm taking. The goal is for them to leave the RICO when we find a permanent housing. We will not be there to assist with the medication, neither we will be there to do the laundry. No. These are the skills you have to learn while you're here that will carry you to be able to be successful when you move in. Let's not forget that most of our unhoused population, they used to live on their own. Something happened that they are where they are today. Either they did not budget very well and they end up on the street, or they had issue with landlord as a result of their psychosis that they end up on the street. I violated my lease by either shouting, talking to myself, not realizing I have mental health issues, not realizing I have a problem. The landlord is talking to me like a normal person when my voice is the one talking. So these are some of the issues that may have led someone back into the street. If we close our eyes on that, the person will likely go back. That's why when I encourage case managers, I ask them to look into where were you living before you became unhoused? What led to you being on the street? If we can address that, we will be coming close to the person not going back to the street. But if we're just working on, hey, I found a house for you, let's move. We have not addressed the main issue that took you to the street, that addressing it is likely where we should go. Now, in some of our, like in Safe Landing, what we do, we have street medicine team. Our vans come to Cecil Safe Landing every Wednesday. That's where we start our medical goal. We encourage people, go ahead, sign up in the morning, immediately they come in, they will start seeing them. Also, the street medicine will start going to DTLA because they are needed. We're seeing a whole lot of medical issues. Staff are transporting them back and forth, that we felt like bringing a street medicine down there would be much helpful. We have a tiny home, also you mentioned tiny home. The street medicine and dental also go there. So it's for us to evaluate what do people need, and we take it to them. We've gone into bringing the phone service, because these days everybody needs a phone. So we've taken them to all our sites to see if they would be able to get a phone, which they have. Because if you're going to make a doctor's appointment, it is your phone that they will be calling for their appointment. They are not going to call my phone. So we look at the basic skill, basic life skill services, and we start from there with most of our clients. So that's who we are. We believe in treating a whole person rather than, if I give you housing, every problem will be solved. It doesn't work most of the time. Yes, housing is needed, but somebody's medical issues and mental health and substance use need to be addressed.
Yeah, you're really speaking to a theme that folks that's incredibly important, of what are the steps that can be taken initially to ensure that that individual is not only housed but remains in housing or is successful. And I don't know if it was Gabriela or Dr. Rob mentioned something also about like growing roots in the community where they end up. where they are placed. And can you talk a little bit about how that's facilitated? Because growing roots somewhere is a deep concept. So I'm curious, for example, here, a lot of folks there's a very strong community in here, and when then someone's placed elsewhere, let's say Long Beach or Wilmington, all of a sudden they're removed from their community, and there's a big challenge there. So can you talk about how you facilitate and support roots growing for folks?
So we have a pretty regimented model that we follow if we're trying to transform. Just think about it. If someone is on the street and they have a serious mental illness and they're chronically unhoused, how would you transform that life? What would it take? Well, our approach is we provide extensive outreach, we provide treatment right there in the street, and then once someone's symptoms have stabilized sufficiently where they don't think that they own massive amounts of property and they have like gold tucked away somewhere that they're trying to find, they're not living in an altered reality. Once we correct that and they're like, actually, you know what, I would like housing, and we move them in. Now, getting someone into housing and supporting them to maintain housing are two separate things. Maintaining housing is one of the most challenging parts of this work because people have, like I said, it's a life transformation. Just think about it for yourself. If you want to even start going to the gym, it can take a very long time for you to get in the rhythm of that. Trying to move into housing is an entirely different concept. What we have found is we provide extra support during that time, and we understand that elopements will take place, people will leave, and we actually go find them, we restart the process in the street and help to return them back and get them comfortable with their environment. We start doing activities like taking people to the DMV, helping them get their benefits activated. We try and help them we try to place all of our folks in housing resources where we have other clients where they can build friendships. We try and use staff members, we try and use facilities where... we try and also admit all of our folks to facilities where we have trusted staff members who are skilled at building relationships. And in the end, it's about having wellness groups, it's about teaching people different types of skills, how to navigate stress, but most importantly, it is about building human connections, new relationships, new friendships with people who you trust and value and build a sense of community. That's what takes the most time. But you have to put someone in a place where they are comfortable, where their needs are taken care of, in a place they can truly call home that feels welcoming. Without that, it's not possible. So we give them all the tools that we need, and we surround them with people that they can build bonds with.
Would you be able to provide an example of that, for if there's a client
yes,
that comes to mind?
I can provide an example of that. There's, I think, one of the greatest, successes in my career was when there was an individual who was completely in a horrible state on the street. We couldn't even provide any street treatment for this individual, and we had to hospitalize him because he was that seriously ill. We hospitalized him at one of our partnered hospitals where they won't just kick you out, they'll wait for us to show up and co-manage this individual because they respect the work that's being done in the street, and at the hospital, realizes they can't do it alone. So we actually show up in the hospital, we continue our outreach, we show pictures of all the different housing options that are available and give people options for which one would you like. We open up Google Maps and show street views. Is this a street you would like to live on? And this person, they picked one of the options that we had in Beverly Hills. It's always nice to say it's in Beverly Hills. And they ended up in that facility, and about 2 months later when I went to visit them again, he was watching the game with someone and just drinking a beer and having a cigarette. And I was like, the idea to go from living in your own squalor in the street to watching the game with a friend that you made, I think that was the essence of building community reintegration.
That was cool. If I may I interject, Dr. Rab? I work in high acuity PSH, and it's not me saying this, my clients say this, that all you're doing is putting a roof over the street. You just brought the street under a roof, and when you do that, it gets exponentially worse. That's not me saying it, that's my clients saying that, and that quite a number of my clients saying that where I work. And it sounds as though PSH is the holy grail and that's the end game. It doesn't always work out that way.
A lot of my folks, I use a lot of boarding care facilities because the people that I work with are very seriously ill. Like these are folks that are like and like almost need conservatorship level. They've been seriously untreated for many, many years. There's been extensive damage done to the brain from untreated schizophrenia, bipolar disorder. So for my folks, I use a lot of boarding care facilities where there's staff to take care of them. There are some people that I have in permanent supportive housing. To be honest, I've noticed some people get lonely in permanent supportive housing sometimes.
Well, it's very difficult for my clients to develop relationships. It's really kind of...
No, it is true. What you're saying is very true.
With the permanent supportive housing, if a client is being moved after many years of homelessness, if they are not being moved with services or programs, it's very, very challenging. I was in FSP for almost, I would say 20 years or 15 years. If the FSP program goes to the home to ensure that things are being done right, we've had success rates. But where a client is just moved here, take the key, and that's your housing, it creates more of a barrier. It creates more of a challenge that client will likely end back into the street. But where there are services, they tend to succeed. Because the fact that I'm being moved into the street, into the house, does not mean that issues that led me to the street are resolved. If it's not resolved, I will end up back into the street.
And it's more dangerous. I think whatever support you had in the street is gone now. If you
Also in PSH, you're stuck. Okay, if you're on the street, you can move your tent 2 blocks over. And I think that's one of the biggest barriers to people, accepting PSH.
Yes, I agree with you. I've had someone who told me she will not go into housing because she was raped inside her permanent supportive housing. But on the street, if she shouts, other people, her community will come to her. So what we did was to explore options to keep her safe, like getting a camera. If somebody comes to your door, you will be able to see who is on your door rather than opening the door. Making sure you call someone, making sure you don't go home with strangers, because it's more difficult when you're living on your own and you are alone. You don't have anybody to talk to, you don't have any family, you don't have any friends, and you don't have a job. People say, and I don't mind, it's a devil's workshop. So you begin to think of things to do. But if you're connected, I'm not asking you to go to work full time. If you're connected, maybe to a volunteer, we're taking people to the library to work as a volunteer. If you're connected, reading a book to some senior citizen center, reading a book to some boarding care will help. It's exploring to say, what are your skills, what can you do? Because yes, I have a house, but I have a job to go to. I come back tired, I sleep. If I'm at home 24/7, I will go crazy. So that's the same notion we should all have if we're putting someone into permanent supportive housing.
And we're gonna have more time for questions in a moment. No, it was great, that's great. No, so there'll be more. Okay, so would it be possible to hold your questions with me?
I can ask, yeah.
Okay, is that okay? You'll remember?
I remember.
Okay, I mean, if you're, okay, good.
I'm sorry, Frank.
No, that's okay, we're good, we're moving along here. So I just wanted to hear a little more from Gabriela about given this kind of, this theme of interim housing as like a stepping stone to maybe permanent supportive housing, maybe something else or some other kind of placement or facility. What are the things that you have found most successful so far although it's a newer program, what have been some of the things that have been, positive? Or what are the challenges, I guess, just kind of branching off of the conversation we're having now?
Yeah, I think a lot of it, the challenges definitely, like, has what's already been shared is that once they go indoors, there's a sense of disconnect from their community. You know, we really do try to look at what community do they want to stay in, you know, and a lot of the times where they've been unhoused at, they previously have lived in that community. And there's a reason why they're there. You know, maybe their mom is still, you know, in that area or a family member. So we really look at those things because it's important for them, and a sense of community because maybe they're outside hanging out the liquor store, and the liquor store, you know, manager, owner, they know them and they feel, you know, protected there because if something does happen, someone's gonna come and help them. So looking at what community is, where they want to be and what community, you know, they want to live in, and we really try to work around that. You know, if we have somebody down here in Service Area 4 and there's an opportunity in, you know, Service Area 2 in San Fernando Valley, most likely it's not gonna work out because we would be taking them away from their community. So we have to look at those things, you know, where do they want to be? What's the next part of your question?
That's great, just kind of what is IHOP doing to ensure folks are successful?
Sure. So having that, you know, a conversation, where do you want to be placed? Where's home for you? You know, do you have family around here? And sometimes, you know, they don't really care, or, you know, that it doesn't really matter. So, you know, wherever it is that, you know, they would want to stay, we really work towards getting them there. And looking to see also their interests. What are their interests? You know, because yes, if they move away from their community, how are we going to maintain them connected? So, and you know, the purpose of our services is also to remain connected to them and provide the continuation of care for them in their new community. So we're an extension, and sometimes, you know, like I mentioned earlier, I came from the home team. We've had clients that, you know, we followed for a very long time because we were their only support system. So how are we supposed to disengage when we're their only support system, right? So what do? We start looking at other resources to start connecting them and engaging them and doing like a warm handoff, like, okay, now this is your different team, they're gonna follow you. If it's an FSP, you know, this is your new treatment team that's gonna be following you. So it really does depend on the client, you know. Our clients are not cookie cutter, you know, our clients come with different needs, and, you know, we have to look at, you know, what is important to them.
Yeah, so I want to talk a little bit, I want to talk about harm reduction and how it's being implemented in the various ways that you all are working now, because that's been a huge theme this year, of course, with this exhibition and the conversations. And then I want to get into a little bit more of some macro questions, but starting first with that, yeah, how are y'all integrating some harm reduction approaches, if you are, and what does that look like across various levels of the services you're providing?
In all our facilities, from RICU to Safe Landing, we have the amnesty locker.
Can you say that again?
Amnesty lockers.
Okay.
Amnesty lockers are like clients safe. We're not asking that you don't use drugs. We're providing the lockers for you to keep whatever you have. We may not allow you to bring in the drug inside, but you have your own locker where you can store whatever you use. And if the lockers are at the door, if you're leaving, you can take it. What we only ask for is for you to use wisely. We have NACANs in all our facility in case. We may encourage as much as we want to use wisely, people still come in under the influence. We've tried, I know since we started Safe Landing, we've had like 3 or 4 incidences where we use the Narcan to resuscitate someone. So it's a question of monitoring, encouraging, and letting them know the issue with drug is not something that you can tell somebody stop and the person will stop right now. It's something I'm used to over the years. It's not something I have control over. Unfortunately, the system have looked at drug as your responsibility. You brought it to yourself without looking at it as an issue, without looking at it as they look at mental health or they look at physical condition. But now everybody are looking at it as this needs to be addressed. So it's a question of giving someone a safe area to talk about it and to let them know this is what you need to do when something like this is going on. So that is where we came, I come from. All our facilities have the amnesty locker. It is for you to put your drugs without necessarily bringing it in. Because we are located in, some of our facilities are in county facilities where they don't even allow smoking, not to talk of use of drugs. But we provide that. You can go outside, smoke, you can go outside and use. It is, nobody's asking you. The only question is the use should not interfere your ability when you come in. If you come in, goes to sleep, there is no question. But when you come in acting up, it interferes with the smooth running of the program. I know we've not kicked anybody out for that. We can sit down, not right now, right there when you're doing that.
Yeah.
When you're in a better mood, I would say, we can then talk to you about your behavior and see what you should do about it. Well, adult is for you to be able to reason and say, did I do that? Yes, you did. Are you really serious? Yes. So that's how we operate with the harm reduction.
Thank you.
So I use the term harm reduction a little bit more broadly. Harm reduction typically refers to substance use. For that, we have a variety of, we use medication-assisted treatment. We can treat with antipsychotics. We can improve person's symptoms. We can actually reduce cravings. We can provide substitutes for the drugs that they're using. But there is a larger form of harm reduction, which I like to think we apply on the home team, which is preventing the trauma that can also come with involuntary hospitalization. Because that is not benign in itself. When you end up in a hospital, you can be put in restraints, you can injure yourself, you're getting injections against your will. It is a dangerous place to be. And just by treating people on the street where they are at, we have been able to avoid hospitalizations altogether or minimize the lifetime number of hospitalizations that people have. So not only are we managing, providing harm reduction supplies to reduce substance use, but we're also trying to prevent people from the harm of the health system itself by trying to avoid acute care, avoid involuntary care, keep people's rights intact and get them into housing.
Here, here.
It's a good point.
And, with IHOP, like I mentioned, we have the Department of Public Health who is providing the substance use education and support. So if we do have somebody that does have what we call a co-occurring use disorder, then we can support them with education. And if they're ready to go into treatment, we can definitely support with that and harm reduction. So the needle exchange program, or Narcan, of course, and those are some of the things that IHOP is definitely taking into account for the harm reduction model. So.
There is one extra piece that we do in the home team, which I think we are very proud of, is if you think about getting someone to a hospital, how does someone get there? You just write an involuntary hold and someone says, all right, let's go. No, that doesn't happen. People run from there very fast.
Yeah.
So usually, who has been responsible for enforcing these hold? It is law enforcement. And what happens when law enforcement shows up? People die. So the home team, we actually, our team created our own protocols for going hands-on, and we actually don't involve law enforcement at all. Everybody on our team is trained to go hands-on and get people on a gurney to get them to a hospital with no law enforcement ever.
That's great.
That's another form of arbitration.
So, okay, so two more questions from me, and then we'll open it up. I'll get with you, Lee, in a moment. Lee, I'm just going to ask a few more questions here. So, you know, this panel is not so much about what happened during the pandemic, right, but what happened now. But I am curious, what is happening now. But I am curious from each of your experiences, being someone alive during the pandemic in your various roles, what are the, from your opinion, what are some of the lessons that are most important, lessons that emerged during the pandemic era in terms of how to care for these folks? That you say are, that you would feel are important to carry forward as more health initiatives are being developed in LA? Whoever wants to go.
I think, to me, being a social worker, having been on the street for a very long time, this is the very first time I saw government take action. When pandemic started, I never knew the unhoused will be removed from the street, knowing fully well how we have dragged our feet. I will start from when, I don't know, if I go back to my life as a social worker, we started the unhoused when we had the first assembly bill called AB 2034, where people are not discharged to the street after jail. We will go straight to jail to pick them up, house them, and then we go from there. When Governor Schwarzenegger came, he removed the funding and claimed that it's all the same. And that's where we are today. I remembered all of us in LA, including your district chief, going to Sacramento, sitting in the lobby of the White House, waiting for him because he was going to remove the funding. But he came out, told us, hey, I'll give you guys lunch after you guys go back to where you came from. So when people talk about homelessness, I look back, to me, I would say the increase in homelessness started when that assembly bill was removed from us. And we went back to the mentally ill, incarcerated, being discharged into the street, and that is what led to all this increase. During that time, we had like few homeless people under the bridge. You go into the freeway, you will spot it, but now it is no longer a secret. It has increased to a tremendous number. So it becomes an awareness for all of us. When COVID hit, we were able to go to that under the bridge to bring out all the homeless. It still showed that we cared. And if we did not care, we could have seen more people dying in LA than in other states. But they were able to be brought out, and they were able to be housed, and things were able to be provided. So I was grateful during that time. I'm still grateful that as a result of using some of these hotels, these continue to be in place where we're housing the unhoused. The interim housing started because I was surprised when they called us in July, hey, can you guys use DTLA as an interim site? We were glad and we took it. Just because the people there were transitioning out and the DHS felt there's still a need, and we were able to step in and start using it as an interim housing. So it's a lesson learned for all of us.
Yeah.
For me, the biggest thing that what I noticed is that I know that the pandemic pushed us indoors and we felt isolated, but in many ways collaboration shot up. I mean, I don't even know how people met before, you know, I had to have in-person meetings, but what I noticed is that after the pandemic, we realized that we can quickly set up meetings, get everybody in your room, make a decision, and go forward. And this idea of recruiting everyone to the table, rapidly making decisions and moving forward, that transformed how quickly we can make things happen. Like, for example, now, if I want to build a partnership with a hospital, I can send them an email and say, hey, we'd like to get together and build a partnership with you. How about we meet tomorrow at 1 p.m. Please send this Teams invite to everybody. Tomorrow, boom, 1 o'clock, everyone's sitting, my team is there, we're ready, we share information, we come up with a plan, we move forward. That could have taken months or before, but now this idea of collaboration has become so rapid that it's really redefined how quickly we can break down silos and bridge them so we can make shared decisions.
Yeah, I think for me, working with the home team through the pandemic, I was able to witness a lot of, like what Dr. Rab said, so many things moving fast and really looking at ways to provide services in a very unique way. You know, the home team was probably one of the only providers still providing services, during the pandemic, in person, out in the streets. We teleworked for maybe like the first week and we said, yeah, we can't do this. We need to be out with our clients. And our teams, I was supervising a big team then, and we realized that we had to be out in the streets. We couldn't be behind, we couldn't be at home in our pajamas, and the need was still there. Our clients, guess what? They needed medication. Our clients needed injections. Our clients needed food. And again, like I mentioned earlier, we were the only, and we still continue to be for a lot of our clients, our only support system. So we continue to do that. We were careful, wear PPE, and oftentimes we look like those, mannequins, thank you. And we got creative, but we did whatever we needed to do to make sure our clients continue to get their daily medication, their food, and the collaboration was great. And we just continued to do what we could with what we had, the resources that we had, and we got super creative. And I think through that process, we continue to now implement those things with IHOP, because we realized that those things worked, and that's what our clients need, because we're going to be their only meal for that day, or probably for that week. So just thinking outside the box, what is it that our clients need, and doing just that.
Awesome. So it sounds like, this is the last one for me, I promise, I think. But so, from what I'm hearing, you all have very on the ground active roles in each of these different areas, home team, IHOP, and the Safe Landing. So I'm curious, can any of you speak a little bit to the emergence of each of those programs, or what kind of macro factors enabled them to exist, like funding, political will? Like, how was it that IHOP actually became a thing? Because there's been things we've identified of what we need and what we want and what we know works, but how did it actually happen? How did IHOP? How was it born? How was the Safe Landing born?
And and then not to say because IHOP came online, the issues have resolved, right? We haven't been on, it's going to be a year, but really we're looking at, how do we continue to provide services and hopefully, then become a countywide program just like home, looking at how we're going to make this happen, make this work, and continue to provide services. lost the question.
No, you're great, but let's backing up. So
Yes.
how is it that IHOP is
Possible,
here? Like,
yeah.
who made it
Yes,
happen?
Thank you.
Yeah.
So we saw the need. A lot of the clients, what was happening, and that's where I was going forward with, are being discharged for behavioral issues. And, IHOP now, that was one of the main reasons why IHOP was developed, because we wanted to look at what are the issues that are happening at interim placements and how can we support, because right now what we're looking at is how can not only we support the clients, but the staff. How do we support the staff from noticing an issue with a client that we can prevent from escalating. So supporting the staff, providing education and training has been one of the major things that we've done and continuing to do. And, how can we keep the clients placed and prevent them from going back into the streets? So IHOP is there to provide that support, whether it's with, mental health, DHS, or, with harm reduction tools.
There's also like opportunities within each department to pitch ideas. So like there's budgetary meetings and they kind of talk about what the budget is like, and you can actually have proposals that go forward. That's how they start. It starts discussions in a room of people who are leaders in this space who identify needs, and they talk about what would help, what wouldn't work, and then they compare that to the budget, and then proposals are made. These proposals then go all the way up to the Board of Supervisors and other county officials, the CEO's office, who decide if this needs to be funded or not. There's many competing proposals that come through. So ideas are generated from within each department. They go through all of these different screening processes, and ultimately they make it to the leaders that decide whether yes, taxpayer money will go towards this. And then all the items and everything get activated. Now here Gabby is doing our hiring. So an idea takes genesis in the department, it's shot up to leadership to decide if it can be funded, comes back down, and then it manifests.
Thank you. Awesome.
Now, for me, I will take it more to a more macro level. We all need to realize that election do have consequences. If we go back to when we started using millionaires, money to pay for mental health services, when we voted that every millionaire in California we will use 1% to support mental health services. After that, when we were able to get enough signatures towards that, it passed, and that's why we still have services today. After that, we go back to homeless, to sales tax being used to support funding services. Without all those initiatives, maybe there will be more mentally ill people on the street. On this ballot also, I think there is another initiative, 0.5% sales tax that will continue to support housing for mentally ill or for the homeless. I can't remember which of that. I know
Measure A.
Measure A, thank you. So I know that those are the things where you and I may say, it doesn't matter, it doesn't concern me, but it do matter and it do concern all of us. Without us thinking about it, without us voting for that, we may lose some of the services that we're getting today. So it's something that we should all be aware of. We are at risk of some of the funding being withdrawn. We are at risk of not serving more unhoused people. So if we can think about it and say, what more do we want? And then be able to vote, we will continue to get the services. That's
I'm going to add to that. You're absolutely right. We can't really have ideas unless there's funding to support those ideas. So if funding streams are open, ideas will generate, and then proposals will go through. So thank you for that.
Awesome. So you're all brilliant. Thank you so much. I want to have some time for engagement and questions. I'm going to start over here.
Yeah.
Yes.
So a lot of the homeless mentally ill aren't aware they're having a delusion and they're not like suicidal, they're not homicidal. So how do you help someone when they think they don't need it? Fine.
That is an excellent question. And in fact, that is one of the things that I have to do as a psychiatrist, is kind of explain things to people who do not think anything is wrong.
Yeah.
And the way oftentimes how would these folks be treated? They would be treated in hospitals. They would be treated against their will. And the way, just because you're not a danger to yourself or others does not mean that you're not slowly endangering your life. For example, if you're not providing for your basic needs, you're not eating food correctly, you're losing weight because your delusion thinks that you can absorb nutrition, you can photosynthesize or something like that, it can cause harm. The way I approach folks is, in many ways, I always tell people, hey, I'm noticing that you're living these conditions, I'm noticing this, you're losing weight, I do have a medication that I believe might help you come out of this. This is what this medication does here, the side effects. Sometimes if they're using drugs, I'll tell them the truth, this medication will protect your brain from meth. With every patient, I have to use as much, I want to use therapeutic privilege. I don't want to scare someone saying, oh, this is an antipsychotic medication, you're going to get all these weird side effects, but I have to be very gentle to provide harm reduction, because if I don't do this and encourage them to take the medication, what's going to happen? You're going to end up in a hospital in restraints and getting injections, all of that down the line. So I want to prevent that from happening by giving them the most relevant information they need and check on them daily in person.
Dr. Rab, can you also elaborate on that a little bit? When we had our interview a couple weeks or months ago, you mentioned how typically, how people think of psychiatry is someone comes into the office saying, oh, I want to go see a psychiatrist, but then in your role, you have to completely turn it on its head and you have to bring psychiatry to the person. So similarly, kind of going off of the question that was just asked, what are some of the other ways that you kind of sell,
Sell the medications?
Not even the medications, but just the care.
Well, I always ask people, my first question is, hey, being out here is hard. Do you ever get sad? Do you ever get anxious? Do you get nervous? And how does that impact? So I focus more on symptoms. Are you accomplishing your goals? Are there things you want to do that you aren't able to get done? And then I'll kind of offer them, okay, I have this medication that helps with improve your motivation, it helps improve your focus, it'll help improve your thinking, it'll help you accomplish your goals. And that's the way I kind of market the medications, because you can't tell someone, I'm giving you this medication, you're delusional, you're not reality oriented, so this medication will help you fix your reality. No one's going to take that medication. You have to come at it from just little goals that you have to accomplish.
I'm a vet, and I know other vets, including myself, when I first got discharged May 27th, 2012, after a 16-year career. What you guys call career, I call a prison sentence. I gladly signed up for. But when I got back home, staying in a room like this here by myself freaked me straight the fuck out. But I can deal with it now. Even though, yeah, my anxiety kind of flares up from time to time, I can deal with it, Yeah. When it comes to fellow vets like me, freshly coming back from, with me, 7 tours, over 144 deployments, and really hostile environments that want help.
The whole family?
But get pushed and put back on the head, not the back burner, but the back burner's back burner. And get told, you're still got 95% of your faculties, all 4 limbs, a missing finger, you can still work. How is that going to get fixed? From not only the psychiatric part, like the mental health part, but the medical, the one-on-one therapy, because I had to basically crawling and scratching for everything all on my own. No help from the VA. I'm still getting 0 after 12 and a half years next month. I'm surviving on only $294 food stamps for the last almost 6 years. How is other vets like me supposed to cope?
Have you applied for, did you ever apply for SSA?
You mean SSI at the SSA office?
Yes, as Social Security.
They told me I could still work, go look for work. I've been out since the 27th of May 2012, which is 20 days after my birthday. So now, in the last 12.5 years, I probably had maybe 18 months worth of experience because they tell me, because of me being a sniper and EOD expert, I'm either too qualified or they're not looking for my type of capabilities. They're telling me to collect SSI and apply for my VA benefits, but I can't only get one or the other if I'm approved for both.
You know, your situation sounds, I feel like you might need to connect with the right kind of people who can navigate that complex system, because, you know, sometimes a lot of these federal and county facilities, they often just get into repeating the same thing over and over, but I believe we have programs over here that can help you kind of cut through some of the barriers that you're facing, especially like with VPAN and stuff. Yeah, we have some services here that can be your voice. If you're having a hard time breaking through with it, we have people who can be your advocates, so they can be your force field, man. I don't think you have to kind of do it alone.
It's getting to a point I'm about to give up my U.S. citizenship and go to England, where I have citizenship there, and Japan through my deceased
Why don't you
Washington.
talk to Cliff, because he just had a,
Yeah,
he just won his SSI case with a good lawyer.
Yes.
Me too.
Yeah, also,
Me too.
he needs help getting
I got my
SSI.
SSI in 2 days.
Yeah, Lee just got back to SSI in a very short time.
It messed me up. The first time I had to stay 13 or 14 years for because my social worker in my house took me to the what you call it, and they put me to sit down right here.
Are there any other questions from folks? There's a long conversation, and maybe we can connect and have more resources provided after. Young Me?
Thank you for everything you're doing. I'm really hopeful because there's so much personal care and longer care also. So that makes me wonder how many cases per person, per caseworker are able to take on because each person is going to need so much care. I mean, obviously some are going to need shorter care than others, but yeah, like caseload and how many?
Yeah, that's a great question. I think for the home team, I can answer that each person holds about 10 folks, which means that each team has about 10 team members. So that's about 100 a team. That's kind of the max that I think they can hold. Each psychiatrist, we have 2 psychiatrists, an MD and a nurse practitioner in each team. And so the psychiatrist holds about 50. The nurse practitioner holds about 50. So each team is carrying about 100 patients. That's the max they can carry. There's usually, they don't get all the way up there because these folks require so much. And even once they're plugged in, things happen. We have to move them up to our caseload. So it's about 100 per team. And we have 18 teams.
So for us, ours is completely different. We carry, it's a team of 3 handling 30 clients. Why I say it's a team of 3, we have the case manager that starts looking into housing. We have the therapist that starts exploring issues related to what brought you to the past, whether you have depression, whether you have schizophrenia or any of the mental health conditions. Then we have the LVN that looks into the medication. So if at times people will say, the case manager will say, oh, I have 30 on my caseload. No, you don't have 30. There are 3 of you handling 30 clients. Each and every one of you may be dealing with things differently. So it's a question of, how am I seeing a caseload? Am I seeing a caseload as me handling the 30 clients? Or am I seeing a caseload that I have you as my partner, and both of us are working together towards that?
Right.
So
So how many are at the Cecil?
at the Cecil Hotel, it's 25 beds that we have, or 25 recliners that we have. And it's as if every day we discharge clients. There is no single day we don't discharge clients. So it's looking into, when they come in, they meet with a social worker to find out what would be their appropriate placement. And if the social worker is able to determine, they go to the case manager. The case manager will then start calling those places. If they're able to find, and mind you, as we are calling, other places are calling. So if the case manager comes and says, hey, there is an opening right here, we work with the driver to transport the client right away. We don't say, hey, take this, go to number 10 Victoria Street. No. The driver and another client aide or peer advocate will take the client to the placement and hand them over to them. Now, I'll be honest with you, we've transported clients. 2 days later, they end up coming back to say, so can I live here? No. It's not a place people live. It's more of a place we can help you get to the next level. Either they're more comfortable there, or I don't know, but at times they've come back asking, can they stay? So.
Did you want to add to that, Gabriela?
Yeah, for IHOP right now, caseloads are looking about 15. We're still fairly new. We may go up to 20. But these are folks that are, again, they're already in interim placement. So, we're giving ourselves a little bit more of, a buffer with clients. So,
Ours have to be kind of tight because we are literally creating an open air hospital around them on the street, so it takes a
more
lot.
high needs with the home team.
Yeah.
Questions?
My question, one, sorry for being late.
Okay,
Two,
you're excused.
What,
Forgive us.
what are you guys most grateful for throughout the entire process of this? And then how could you, for just a general person of the public, what would you convey to them just to get more involved or be more aware of how, if they saw something in yourself, how they could
Voting, for sure. That's how you can get involved, and going to community meetings, definitely getting involved with, what's going on, what are the propositions, to get more funding. What I'm most grateful for, I've been in this field for many years now, and the connections I've made through my colleagues. I've worked with Dr. Rabs for many years, and just continuing to build on those foundations of my colleagues and resources. If I don't know something, I can call somebody, I can text somebody, and they can help me out. Because something you mentioned, it does take a village. I know we use that a lot, but it definitely does. So, thank you for your question.
That's a great question. It's an emotional one on many levels for me, because what am I grateful for? In many ways, I am grateful that all of this has been possible. And, we never know how we end up in positions where we are. To be honest, part of the reason why I even came to Skid Row was to shorten my commute. I was driving really far, but in the end, life positioned me in a place, and it surrounded me with people who were willing to make magic happen and build something that never existed before, and they had my back along the way. And I had the opportunity to work with my clients who agreed to trust me, who agreed to take a leap of faith with me, who allowed me to reunite them with their families, and to have this experience of feeling what humanity really is at its finest. I think that's what I'm most grateful for.
What was the question?
Yes, there's a very good way. I think the only way that we as a society can probably address something as complex as homelessness is to all be on the same page about it, and act as there should be a pathway that we all activate instead of everybody having their own kind of approach. But one thing you can do to connect anyone that you're concerned about with us is to actually connect them to the first line of defense against being unhoused, which is outreach. And if you go to IHOP, IHOP stands for the Los Angeles Homeless Outreach Portal, you can complete that for anybody. And that'll open up the first line of defense for outreach. If that doesn't work, it'll go to specialized outreach. If that doesn't work, it'll come to the home team. And then from there, you get to IHOP. So that's your entry point into the entire system. And we actually have coordinated outreach meetings where we review all of that. It'll directly connect you with the home team.
To me, what I'm grateful for is seeing people housed, moving out from this street and into a setting that is not outside. Be it RICU, be it any type of housing. I don't know if you guys are aware, we will be opening up a boarding care down on Crocker.
Yeah.
And it's a 48-bed facility. And that came about because people were able to look in the community and realize that when people are aging, it's no longer my parents or my mom, my parents or my relative, that our community are also aging, and there are people in that community that will need different level of care. Seeing that coming up, and seeing some of the unhoused lying on the street that are not able to walk or able to do a whole lot for themselves, it's a need that we will all cherish within this community. So it's something that I'm happy, it's something I'm proud of. I didn't know it would get to that. We walked out from a meeting, and I remembered one of the DHS person asked me, "Can you guys write a grant for boarding care?" I'm like, "Boarding care? We've never really done boarding care." I'm like, "Okay, are you sure?" Yeah, that's how it started. And today, I will tell you, maybe by December, January, the door will open for those that need that services. Many people don't want to leave Skid Row. This is who they are. This is where they have their community. Why move them to a boarding care in Santa Monica because they cannot care for themselves? So that's what I'm most happy and proud of. The second one is people are willing to help. When we started Safe Landing, I took one of my kids to the doctor's office, and she was like, "What do you do for a living?" I'm like, I work with the homeless. That's how I describe myself. "You work with the homeless?" I'm like, "Yeah, where? Skid Row." "Really?" "Yeah." "Oh, okay." She rushed out, talked to another doctor. "Do you know she worked with the homeless in downtown?" The doctor came in and said, "What do you guys need?" I said, "Shoes." "Oh no," he asked, "Do you guys need shoes?" I said, "Yes." By the time I came back for the next visit, all of them at St. Joseph Burbank collected so many shoes for us. So she called me. I'm like, "Okay, can you come to my office? We have a surprise." I went there, they gave me a big bag of shoes with different sizes. I took it to Cecil thinking, this is a lot. Where are we going to keep this? But they were gone within a week.
Wow. Yeah.
Gone, completely gone. I was happy that people used it, but I was surprised that the whole shoe were gone. So at times I'm happy about that. For my kids, they play football. They may not have gotten to that level, but they gather their friends to donate summer wares. Like, I brought it here. Mom, do you need this? Yes, I do. I'll bring it here. My happiness is seeing those things in use. Seeing that someone is making use of it. It's not in someone's closet collecting dust, but being used. So.
Okay.
One more, I promise
Yeah.
it. So I know when a lot of people hear of homelessness, they think of substance abuse, crime, et cetera, et cetera, et cetera. Do you feel like if we were to change the narrative of what homeless is, the public would be more willing to help, to get involved, rather than what the unfortunate negative narrative of it is?
That's one thing that's been my personal mission, which I try to do a lot of media projects to show people's lives transforming for when they were on the street, when they weren't. Like, unfortunately, drugs and crime are natural things that happen when someone is living on the street. You just can't really, it's not that what caused it, it's just associated with it. And I think that there needs to definitely be a huge campaign to educate the public on what the reality is, so they don't see a criminal, they don't see a drug user, they see someone in need. That narrative really should change.
One thing we should realize is this. Not everybody that is unhoused or homeless started using drugs. Some people started using drugs while they are homeless. They either used it to mask the condition, they either used it to get by. So looking at it as it's homeless, it's your drug use that took you to homelessness. No. It's something that people don't have a complete narrative of what leads to homelessness. I remember going to school and my professor asked us, why are you different from the person on the street? We were all yapping. And he turned around and told us, we all are one paycheck away from being homeless. And it's not a lie, because if you look at your salary for those of people that have a job, you will realize that your rent is 60 to 75% of your paycheck. That if you don't have that, your rent or your mortgage for 2 months or 3 months, you will be on the street. So it's something that was a rude awakening to all of us that were like, oh, that is actually true. Because when he asked us, write down how much is your rent, we did. How much do you make a month, we did. Then when we compared it, we found out that if you're not in a Section 8 housing, your rent or your mortgage is like 60% of your salary. And if you don't have it for a month or 2 or 3, you will be homeless. Unless you have a family that so much care for you, that will take you in. But by the time you live from here to here to here and you don't have a job, you will be an obstacle, which is what also sent some of our unhoused people into the street. The family were burnt out, they don't want to deal with them, and they ended up walking away.
So I just want to thank you so much, everyone. I want to pause for a moment to just shout out Dr. Jen Sodarski, who is about to walk out the door. But before she does, I wanted to just capture her for a moment. To just, because Jen is like a huge force behind this entire project, connecting us with all the individuals, not to mention just the work you actually did to make this all happen in your role during COVID and post, and just the fire you had to keep this all going and really support LAPD in making this happen. So before you leave tonight, do you have anything you want to share just about what it's like to have done this, and last words or anything you want to say to these lovely folks before you make your way home?
Well, first of all, thank you so much, you guys, for coming out on a school night, and Clancy for maintaining the pep. I think when I met John at a think tank, and I had never really. We were so in the thick of COVID, I hadn't really appreciated the value and of what we were doing long term. And it brings me so much pride to know that, that this and the endeavor of the COVID hotels and as it lives on in you guys is being, is sort of being archived here at the Skid Row Archive and LAPD. I'm just so grateful for that, and also just for your creativity in the vision. That's it. So, it was unexpected.
Thank you. I'm happy to hear you.
I'm really proud of having been a part of it.
Awesome. Great. Amazing. Well, does anybody have anything else they'd like to share? I know it's getting a bit late, so any last questions?
There's a question.
Oh, yeah.
What are some of the biggest challenges and or obstacles you face while trying to do your job?
I guess they're very good. Other doctors. Other doctors have been a very challenging. You'd be surprised. You would think that doctors would tend to help doctors, but actually people are very set in their ways, and they like to be in their structured environments and siloed off, and this is how the health system has been for decades. And here you come along and you try and say, I'm giving you a report, and you're like, who are you? We've never received a report. So trying to change the way hospitals and traditional systems of care operate, to build an entire new level of care, I had to go through a ton of doctors who said, no, who the hell are you? This is a facade, we don't work, until I found physicians who were like, hey, this is something that we really now partner up with you. So other doctors were a huge roadblock for me, surprisingly.
Okay.
Interesting.
For me, staffing.
Staffing.
Majority of the time, you're not able to get the number of staff you need to cover the shift. And when you even get the staffing, you end up not getting the right staffing, or you end up getting someone who calls out sick every day. I'm not saying you're not sick. So it boils down to staffing.
Oh, okay.
So, yeah.
For me, IHOP is just so fairly new. I think it's just more of a systems, we need to get this program off the road like months ago, right? That my system, DMH, is not moving fast enough, but that's just, department thing that, it's just not it's not moving fast enough, because we have these demands and needs for our communities to expand and staff, and and that's just an internal thing. And it's, also, we're short-staffed, and, but just staying creative and making the best with what we have. Yeah.
Okay, thank you.
Absolutely, thank you. I think the most, something that's really important, and Gabby, you talked about this, how one of the main things that you're doing in IHOP is educating the staff in the interim housing.
Yeah.
And you're talking about staff, and you're talking about doctors. And my fantasy is that the next spin-off is going to be some sort of some broad education, trauma-informed harm reduction education program that goes to the hospitals, that goes to interim housing, goes to PSH.
I'm actually trying to change that, because we, at least on the home team, we set up a residency program, rotations for the future generation of doctors, so they come learning this stuff from the ground up, and they kind of, my idea was like change from within. And these are the doctors that run the ERs and all of the other things with their resident trainees, and they run these hospitals. So at least I'm trying to do that for the doctor side, so I have my sleeper agent.
Yes, I agree with you. Very good. Because I remember graduating in social work. When you hear therapy, social work, you think you'll be sitting in a big office in Beverly Hills and asking, how do you feel, right? Coming out, the first job I got was with this population. And fortunately, we had a very good program in my School of Social Work, USC, After a month or two, 3 months after working in the job, we meet to share the experience. So I embraced this, we met, and the professor was asking us how everything was going. Unfortunately, our mindset in school was completely different from what we're seeing in the field. I was the only person that embraced the Partners program. Most people were still looking for a job, waiting to find that therapy where they can cognitively challenge you, ask you how you're feeling. And the professor was like, you guys are now in the real world. Unfortunately, what we do in school may be different, but this is what we have. I felt like asking, why don't we bring it to the ground level? Mm-hmm. Why don't we start from the grassroots rather than starting above? Well, there were explanations behind that. It is the basic principle of being a social worker that you are trained. It's now for you to navigate the system, taking it, and then knowing how you take what you learn and apply it in every setting that you learn. Right. So, it's still good.
Can I just inject one thing that is just in my brain? Because I just read it in the New York Times, to say practice-based evidence instead of evidence-based practice. I thought that was so good when I read that. I mean, I've been looking for term like that for years.
Yeah.
That's
Dr.
it.
Bond special.
That is totally it.
Wait,
Yeah.
run that back again, practice-based evidence?
Yes.
As
opposed to evidence-based practice.
As in the reality in the field informs, the decision rather
Yeah,
than.
because the term evidence-based practice, I always would ask, like, what qualifies as evidence?
Exactly.
You know, it's like, who came up with this evidence? What qualifies as evidence? Why is not evidence, et cetera, et cetera, et cetera.
But this is the practice.
Okay.
Yeah.
Practice-based
And then we have some evidence.
Yeah, where do I find this practice-based evidence?
John has a question.
Yeah.
Well,
This is our final question.
It's really not a question. I want to think about what Jen said about, the future of this project. Yes, we're archiving this stuff, but we're also, LA Poverty Department is a theater group, and a lot of the people in this room are in the theater group, and we've been making a performance about the QI sites and what happens afterwards. And what is important about the QI sites is it's a physical location that people can go to, and that's what's important about the safe landing. And we want to see, and that's what's important about the health campus that's going to be set up. It's going to be in Skid Row, and we're going to be actually doing stuff there. And we want to see these kind of things. And it came out of these conversations, actually, where people like Tina Juarez said, we want to see these in every spa in every neighborhood of the county. And so we're making a performance advocating for that. We intend to do it in all the different spas of the county with a performance about 50 minutes long with panels as well. And because we believe, and I believe, living where I do in my neighborhood, I mean, I live in Mar Vista. So there are people in Mar Vista that I know on the street that but I feel like an idiot on the street out there because there are no services, there's no place to take someone to, that I'm aware of, but if there were a place, if there were a safe landing place there, not only me, I believe that we could activate, like thousands of Angelinos who actually are compassionate people and do engage with people in their neighborhoods, but then don't want to call 311 and find out that nothing happens. They want to be able to take someone to an actual spot and make it just like whoever said it. We do the handoff ourselves. We don't just you said it. We don't just send something. Okay, go to this address and take care of it. No, we want to go and walk to that place with this person that you have a rapport with, and I think that's the way we could activate enough people in LA County to actually, to actually, make huge inroads into changing the situation.
Yeah.
And other than that, I'm in awe of what everyone here has said and what you all do.
Thank you for having us.
Thank you.